Hi, welcome to our fourth tutorial in hematology, and in this tutorial we're going to focus on hemolytic anemia. Okay, hemolytic anemia. So these are just practicing questions where you have to apply the knowledge that you've studied or the notes that you've read, and also those notes can be from your books, from the lecture slides that you're using, and also other sources of hematology books and also research papers. So this is to actually guide you on some of the many aspects of hemolytic anemia, right? Use this as a guidance so that you just apply and relay the information that you've already read. All right. So this is Clement Chilambe from Clement Chilambe Medical Tutorials, and therefore I welcome you to this tutorial, and we shall start right away. So this is hemolytic anemia, and I am sure that you've read something about hemolytic anemia, and we're going to start with our first question here. So this question is very important because hemolytic anemias, remember, we are talking about the normal red cell. Okay, the red cell, what happens to it? Okay, so the first question is saying normal red cell's lifespan is A, 60 days, B, 90 days, C, 120 days, and D, 150 days. All right, what is your answer? So we know that a red blood cell circulates for approximately how many? 120 days, right? So the answer is C. We know that the red blood cell circulates for approximately these days, which is 120 days. And after this period, there is what is known as the age-related changes will signal the macrophages that macrophages are of the reticuloendothelial system, right? Primarily, this happens in the spleen. So what happens then? After the signaling of these macrophages of the reticuloendothelial system, they remove these red blood cells from circulation. This is actually a fundamental concept. That's why this question was put here, because this is actually a fundamental concept, because hemolytic anemias are defined by the what? Significant shortening of this very lifespan. Therefore, this question was actually important. We go to the next question, which is question number 2. Okay, question number 2. The red cells are removed extravascularly by A, macrophages of the reticuloendothelial system, B, liver, C, spleen, D, or of the above. Red cells are removed extravascularly by, the answer is all of the above. Actually, the answer is all of the above. Okay, can we explain why we are saying that red cells are removed extravascularly by all of the above things that we've mentioned? We know that when we talk about the extravascular hemolysis, it is one of the most predominant mechanism of the red blood cells destruction. So here you find that red blood cells are phagocytosed and they are broken down outside the blood vessels by macrophages. That's why the term extravascularly is very important to understand. So these macrophages, which are just located throughout the reticuloendothelial system, with the spleen and the liver being the primary organs responsible for this process, we are therefore eligible to point D as the correct answer, because these three choices here, A, B, and C, are all involved in removing red blood cells extravascularly. We go to question number 3. Okay, so question number 3. Hemolytic anemia may not be seen until the red cell lifespan is less than A, 15 days, B, 20 days, C, 25 days, D, 30 days. Look at this question. Hemolytic anemia may not be seen until the red lifespan is less than what? So we know, before we get to the answer, the bone marrow, remember, it has a remarkable capacity to compensate for increased red blood cell what? Destruction. How? By increasing the production, which is the erythropoiesis. Now, of course, it can produce red blood cells at least 6 to 8 times the normal rate. And when you look at the clinical signs of anemia, the clinical signs of anemia only become apparent when the red blood cells lifespan falls below the compensatory threshold, typically 30 days, or typically around 30 days. Okay, so we are getting this as the correct answer to this question here. So hemolytic anemia may not be seen until the red cell lifespan is less than 30 days. So our answer is D. Okay, question number 3. The normal adult marrow is able to produce red cells at A 2 to 3, 4 times the normal rate, B 4 to 6 times at the normal rate, C 6 to 8 times the normal rate, 8 to 10 times the normal rate. Which one is the correct answer? I think I even explained in the previous explanation that 6 to 8 days the normal rate is the answer to this question. The normal adult marrow is able to produce red cells at 6 to 8 times the normal rate. Okay, this signifies the importance of what we call the reserve capacity, isn't it? The bone marrow's significance of what is known as the reserve capacity, because there's the compensatory hyperplasia. Okay, that is why patients with, let's say, chronic hemolysis can often maintain a near normal hemoglobin level until the hemolytic process becomes very severe. Okay, so 6 to 8 times the normal rate is actually the correct choice that we are going to go with. All right, question number 5. Hereditary hemolytic anemia. Okay, hereditary hemolytic anemias are the result of A, extracorpuscular changes, B, environmental changes, C, intrinsic red cell defects, B, both A and B. Hereditary hemolytic anemias are the result of which one do you think is the correct answer? Okay, so look at these keywords that we have here. Hereditary. Okay, so hereditary hemolytic anemias, first of all, are caused, just to be specific, these are caused by defects within the red blood cell itself, right? They are hereditary. Okay, so these are classified as intrinsic. Okay, they are classified as intrinsic. So they are intrinsic red cell defects. And when we say intrinsic red cell defects, we normally include the abnormalities of the cell membrane. Remember, I think we discussed this in our first and second tutorials. So giving an example of hereditary spherocytosis, and also giving an example of, okay, so hereditary hemolytic anemias cannot only be, can actually include abnormality of the cell membrane, and also not only the abnormality of the cell membrane, I've remembered this, it can also include the abnormalities in hemoglobin, given an example of sickle cell disease and also thalassemia. Or it can actually include the abnormalities of the what? Enzymopathies, the enzymes, such as, remember, the G6PD deficiency. So we are saying that intrinsic red cell defects are, they result or comes out because of hereditary hemolytic anemias, or hemolytic anemias are the result of these, because yeah, in that way. So C is our best answer here. Number 6. Acquired hemolytic anemias are usually the result of what? Acquired hemolytic anemias are usually the results of what? A, intrinsic red cell defects, B, extracorpuscular changes, C, environmental changes, D, both B and C. Which one do you think is the correct answer on question number 6? So look at the choices that we have. First of all, you have to remember that there's a difference between hereditary hemolytic anemias, and also there's a difference between acquired hemolytic anemias. Okay, and that difference is that when we talk of the hereditary hemolytic anemias, we normally refer to intrinsic factors, or internal factors rather. Then when we talk of acquired hemolytic anemias, we refer to external factors. So all those factors that are external to the red blood cells, that includes what? That includes B, okay, extracorpuscular changes, okay, which in this case also includes what? The environmental changes. So therefore, if B and C, we are saying that can cause acquired hemolytic anemias, or are they comes about because of acquired hemolytic anemias, then we are saying that extra corpuscular changes and also environmental changes are the answers, and therefore we say D is the correct answer. We also need to take note that when we talk about environmental or immune-mediated changes, extracorpuscular changes, I've already said, all these can cause acquired hemolytic anemias. And also, the best example when we talk of immune-mediated is the autoimmune hemolytic anemia. And it can also be because of toxins, it can be because of infections, and also mechanical trauma, when we refer to artificial heart valves. So we are saying B and C are the only available options according to the things that we've actually discussed here. And therefore, we move to the next question, which is question number 7. Okay. Okay, so question number 7. Which of the following is a clinical feature of hemolytic anemia? A. Pallor of mucous membranes. B. Mild fluctuating jaundice. C. Splenomegaly. And D. All of the above. Which of the following is a clinical feature of hemolytic anemia? So you need to understand the question. It's not saying which one of the following. So when you meet a question like that, which one of the following, means that D is automatically wrong because saying all of the above, right? But there are instances where they can actually refer to D as which one of the following. Now, which of the following is a clinical feature of hemolytic anemia? Okay, so when we talk of the pallor of mucous membranes, of course, this is a clinical feature of hemolytic anemia. Mild fluctuating jaundice, this is a feature of hemolytic anemia, and splenomegaly also is a feature of hemolytic anemia. Remember, when you talk of pallor is due to the anemia itself in hemolytic anemia, and jaundice comes about because there is increased breakdown of hemoglobin, leading to what is known as the unconjugated bilirubin. Then we talk of splenomegaly. Remember, the spleen itself as an organ is the one that is involved in the destruction of RBCs, and since it's the organ that is involved, it's enlarged. It becomes enlarged because it works hard to remove the damaged cells. All right, so we are saying that all of the above is the correct answer. And by the way, when you go for hemolytic anemia, all these, the three, this is a triad: pallor, jaundice, and splenomegaly. It's a triad. It's a clinical triad of hemolytic anemia. All right, so let's go to question number 8, question number 8. So bilirubin is in the urine. In the urine in hemolytic anemia, A is always present, B is absent, C maintain dark on standing due to excess urobilinogen, D both B and C. Okay, so bilirubin in the urine in hemolytic anemia. What do you think is the correct answer? Okay, so look at this. Unconjugated bilirubin itself is not water soluble, that we must know. And since unconjugated bilirubin is not soluble, another fact that before we even get far that we need to remember is that the unconjugated bilirubin, because it is not water soluble, it is also bound to albumin in the plasma. And therefore, since it is bound or is bound to albumin in the plasma, it is absent from where? From the urine. Okay? But, or let's just say, however, the excess bilirubin processed in the gut leads to what is known as increased what? Urobilinogen. Urobilinogen is absorbed and also excreted where? in the urine. So upon standing, urobilinogen, this compound here, can oxidize to urobilin, causing the urine to darken. And from that explanation, we are saying that bilirubin in the urine in hemolytic anemia is absent and may turn dark on standing due to excess urobilinogen. So B and C are the true answers, and therefore answer D is the correct choice. Okay, let's go to question number 9. Which of the following is a feature of increased red cell production in hemolytic anemia? A. Reticulocytosis. B. Bone marrow erythroid hyperplasia. C. Reduced myeloid to erythroid ratio. D. All of the above. Which of the following is a feature of increased red cell in hemolytic anemia? Okay, this is straightforward because we know that the bone marrow compensates for the loss of RBCs by increasing what? Its production. So now, when we say increased by increasing production, we are saying that, of course, there is reticulocytosis. An increased number of young immature RBCs known as the reticulocytes in the blood. So this one is there. Then bone marrow erythroid hyperplasia. Okay, so the bone marrow space is hypercellular. Okay, so in this case it's hypercellular with a disproportionate increase in what? In erythroid series, or in some other ways we are going to say the red cell precursors. Okay, so this one is there. Then the third one, reduced myeloid erythroid ratio. Okay, so the normal balance between the white cell precursors, and which are known as the myeloid, and the red cell precursors shifts in favor of what? The red cells. Okay, so red cell production. So there is this, of course, there is reduced this, and therefore the answer D qualifies. All of the above are features of increased red cell production in hemolytic anemia. All right, so question number 10. Go to question number 10. Which of the following is a feature of damaged red cells in hemolytic anemia? Microspherocytes, elliptocytes, red cell fragments, schistocytes. D, all of the above. Which of the following is a feature of damaged red cells in hemolytic anemia? Okay, so let's now analyze. When you talk of microspherocytes, elliptocytes, and also red cell fragments, these from your notes, from your slides, you might be able to spot them, or to note that there are some common features also. Why are we saying this? Because when we talk of in anemia diagnosis, we use the peripheral blood smear. Okay, so the peripheral blood smear is very crucial in diagnosing hemolytic anemia, because there is a change in the shape of RBCs, which often points to the underlying cause. When you talk of spherocytes are seen in hereditary spherocytosis itself, and also in autoimmune hemolytic anemia. That's where we talk about the autoantibodies and everything. Then we talk of elliptocytes. These are also characteristics of hereditary elliptocytosis. Okay, damaged red cells. These are features. Then red cell fragments, which are schistocytes. These are, because they are fragments, they just indicate what? The mechanical damage. An example is the microangiopathic hemolytic anemias. So we are saying that all of the above is the correct choice. Okay. Question number 11. In intravascular hemolysis, the main laboratory findings include A. Hemoglobinemia and hemoglobinuria. B. Hemosideruria. C. Methemobaminemia. And D, all of the above. So in intravascular hemolysis, remember that when we say intravascular hemolysis, this is the destruction within the blood cells, and this releases hemoglobin directly into the plasma. So when we talk about hemoglobinuria, okay, hemoglobinemia, this This is about free hemoglobin in the plasma, where we get to see the pinkish serum, right? And then we talk of hemoglobinuria. This is the hemoglobin that is excreted in the urine. The urine tends to be dark brown, okay? And then when we talk of hemosideриnuria, this is iron. Hemosiderin, remember, this is iron from hemoglobin, which is taken up by the renal tubules, the tubule cells, and also after being taken by the renal tubule cells, they excreted in the urine as hemosiderin, that is days later. Okay, and then talk of methylalbuminemia. This is the hemoglobin that is bound to albumin, forming methylalbumin. Okay, so we are saying that all of the above is the correct answer also. Okay, so all these. We move to the next question, which is question number 12. Autoimmune hemolytic anemias are characterized by positive antiglobulin test, antibody production by the body against its own red cells, both A and B, D, neither A nor B. Okay, so autoimmune hemolytic anemias are characterized by positive direct antiglobulin test and also antibody production by the body against its own red cells. All these actually points out to autoimmune. The word autoimmune is the key word, because when we talk about autoimmune hemolytic anemia, we define this as the production of autoantibodies that target the patient's what? On RBCs. And when we talk of the direct antiglobulin test, okay, positive direct antiglobulin test, the DAT, or in other words, the Coombs test, it is actually one of the key diagnostic tests that are performed, and they actually detect these antibodies or those complement components which are coated on the surface of the patient's red blood cells. So we are saying that there is a positive antiglobulin test in autoimmune hemolytic anemias, and also there is the antibody production, the autoantibodies by the body against its own red cells. All right. Warm autoimmune hemolytic anemias are characterized by A, antibody reacting more strongly at 37 degrees Celsius, antibody reacting more strongly at 4 degrees Celsius, IgM antibodies, and D saying both B and C. Okay, so warm autoimmune hemolytic anemias, this is very direct, okay, is the most common type that we must know, and also the autoantibodies that are actually involved are typically the IgG, and they bind optimally at body temperature, which is what? 37 degrees Celsius. So this leads to what is known as the extravascular hemolysis, primarily that is seen in what? In the spleen, as we discussed. So from this statement I've said, you'll be able to, of course, agree with me that antibody reacting more strongly at 37 degrees is the correct answer here. All right. Question number 14. In warm autoimmune hemolytic anemias, the red cells are coated with IgM, that is A, then B, complement, C, IgG alone or with complement, D, both A and B. That is in warm autoimmune hemolytic anemias, red cells are coated with what? Which one do you think is the correct answer? I think we just whispered an answer from the explanation that we gave on question number 13. And from that question, you can actually see that we mentioned immunoglobulin G, IgG. Okay, so in warm autoimmune hemolytic anemias, the direct antiglobulin test itself is positive for IgG, and it is together with the complement, the C3D. Yes. So the immunoglobulin G that is coated on the RBCs are recognized by the macrophages in the spleen. So when they are recognized by the macrophages in the spleen, this leads to the partial phagocytosis and also the formation of what we did talk about, which are the spherocytes. Okay, damaged red cells, spherocytes. So this is actually the correct answer. IgG alone or with complement. Okay, let me delete this and put the correct thing. Okay, so we are saying IgG alone or with a complement. All right. So let's move to the next question. Evans syndrome is the association of autoimmune hemolytic anemia with A. Idiopathic thrombocytopenic purpura, B. Aplastic crisis, C. Pigment gallstones, D. None of the above. Evans syndrome is the association of autoimmune hemolytic anemia with. So Evans syndrome is actually a specific condition. Okay, Evans syndrome is a specific condition where a patient simultaneously or sequentially develops two autoimmune cytopenias, which are the autoimmune hemolytic anemia and also the immune thrombocytopenic purpura. So we are saying the idiopathic thrombocytopenic purpura are actually the association of autoimmune hemolytic anemia in Evans syndrome. Right. 15. In cold autoimmune hemolytic anemias, the antibody is usually A. IgG, B. IgM, C. Directed against the T antigen, D. Both B and C. So in cold autoimmune hemolytic anemias, the antibody is usually, let's look at A. So look at this. This is cold autoimmune hemolytic anemia. And cold autoimmune hemolytic anemia is characterized by the IgM and autoantibodies. And these IgM autoantibodies are the ones that optimally binds to what? Binds to RBCs at cold temperature, which is, what's that? 0.024 degrees Celsius. Yes, it's 0 to 4 degrees Celsius. So the most common specificity is against the what? The antigen system, the I antigen system on the red blood cells. And therefore, we are saying that this one, both B and C, is the correct answer here. Okay, so these two are the correct choices. In cold autoimmune hemolytic anemia, the patient may develop A. acrocyanosis, B. splenomegaly, C. mild jaundice, D. all of the above. In cold autoimmune hemolytic anemias, the patient may develop what? What is the correct choice? Okay, so when exposed to the cold, we need to realize that the IgM antibodies will bind to what? They bind to RBCs, and when they bind to red blood cells, they cause the agglutination or the clamping, okay, in the capillaries of the ends, the extremities. Yeah. And when there is that agglutination or clamping of RBCs, what happens then? The blood flow gets blocked, leading to acrocyanosis, which is characterized by a purplish discoloration of the fingers, the toes, the nose, and also the ears. Yeah. Well, jaundice and splenomegaly can occur, but acrocyanosis here is a distinctive feature of cold autoimmune hemolytic anemia. And therefore, we are saying we are only considering what? Acrocyanosis as the correct answer here. All right. Question number 18. Autoimmune hemolytic anemias can result from A. Transfusion of AB or incompatible blood, B. Rhesus disease of the newborn, C. Allogeneic transplantation, and D. all of the above. Autoimmune hemolytic anemia can result from what? So autoimmune hemolytic anemias can result from all these things that we've talked about. Why? Because autoimmune hemolysis occurs when antibodies are formed against foreign RBCs antigens. And therefore, what do we mean by foreign RBCs antigens? Let's give examples of this. When we talk of ABO incompatible transfusions, we know that the recipient is pre-formed antibodies who attack the donor RBCs. And then when we talk of B here, hemolytic disease of the newborn, when we talk about the hemolytic disease of the newborn, the maternal antibodies will cross the placenta and also attack the what? The fetal red blood cells. Okay, and then allogenic transplantation. This is where now the immune cells from the donor, known as also the graft, can attack the what? The recipients, which is the host, RBCs. So immune cells from the donor can attack the recipient's what? RBCs. So we are saying, what are we saying? We are saying that all of the above can result from autoimmune hemolytic anemias. Okay. Number 19, drug-induced immune hemolytic anemias can occur via which of the following mechanisms? Drug-induced, remember, A, antibody directed against a drug red cell membrane complex, B, deposition of complement via drug protein antibody complex, then C, a true autoimmune hemolytic anemia, and D, all of the above. So drug-induced hemolytic anemias can occur via which of the following mechanisms? All right, so drugs can cause hemolysis through these three main mechanisms, just to be specific. How? When you talk of the first choice here, the drug's red cell membrane complex, we recognize the drug adsorption or the uptake drug adsorption. So these drugs will bind to RBC's membrane and the antibody will form against the drug. An example of that drug can actually be penicillin, okay? Can be penicillin. Then when we talk of deposition of the complement via drug protein antibody complex, we refer to the immune complex itself, where the drug antibody complex will bind non-specifically to what? To RBCs. They will bind non-specifically to red blood cells, activating the complement. An example of a drug here is the quinidine, the quinidine. Okay, I'll just put so that you can remember the quinidine. And then see a true autoimmune hemolytic anemia. This has to do with autoantibody. Drug induces the production of autoantibodies, right? That will attack the RBCs, even in the drug's absence. Methodopa is actually a critical and a true example here. Methodopa. All right. So we are saying that all of the above are mechanisms by which drug-induced hemolytic anemias can occur. Red cell fragmentation syndrome can be caused by what? So red cell fragmentation syndrome can be caused by A, abnormal surfaces like artificial heart valves, B, microangiopathic hemolytic anemia, C, disseminated intravesicular coagulation, D, all of the above. Okay, so red cell fragmentation can involve, of course, what is known as the mechanical shearing, right? Mechanical shearing of the same red blood cells that we are talking about. When we talk about the macroangiopathic, okay, microangiopathic, there's physical damage that is done from abnormal surfaces like the aortic stenosis, and also in prosthetic heart valves, you find that there's physical damage from abnormal surfaces. And we talk of microangiopathic, you find out that for microangiopathic, there is damage from the fibrin strands in these small vessels, and this is seen in the disseminated DIC, disseminated intravesicular coagulation. It is also seen in TTP, okay, thrombocytopenic what purpura, thrombotic thrombocytopenic purpura. I'm just giving examples here in case you need them. And then hemolytic uremic syndrome, of course, when you talk of hemolytic uremic syndrome, don't mind what I'm doing here. I'm trying to think also. Okay, hemolytic uremic syndrome. So these are actually examples of the microangiopathic that we're talking about and macroangiopathic. So we are saying A, B, C are correct answers, and the D is not really our correct answer in this case. Right. Number 21. Much hemoglobinuria is caused by what? A, damaged red cells between the small bones of the feet. B, prolonged marching or running, absence of red cell fragments in the blood film, and all of the above. So much hemoglobinuria, when we talk about this condition, it's actually a benign thing. Self-limiting condition which is caused by what? The mechanical trauma to RBCs in the capillaries of the feet during prolonged or strenuous exercise. Okay? So the hallmark of much hemoglobinuria, is intravesicular hemolysis. That's why hemoglobinuria is coming in, isn't it? Without the presence, you need to take note of this, without the presence of the schistocytes on the blood smear, that is what distinguishes this much hemoglobinuria from other fragmentation syndromes. So what are we saying? We are saying that all these are causes of much hemoglobinuria, right? Infections can cause hemolysis by what? A, precipitating acute hemolytic crisis in G6PD deficiency, B, causing microangiopathic hemolytic anemia, C, extravascular destruction of parasitized red cells in malaria, and D, all of the above. Infections can cause hemolysis by how? 22. Okay, do we agree that precipitating acute hemolytic crisis in G6PD deficiency? This is very correct. Very correct, because when you talk about oxidative stress, right? So oxidative stress, these infections can precipitate crisis in these G6PD deficient individuals. Yeah, so if the first one is correct, and we need to take note that the infections themselves are a common trigger for hemolysis, and this is one of the pathways. The other pathway, I'm going to agree with B, because they are saying causing microangiopathic hemolytic anemia. Yes, when there is severe sepsis. Severe sepsis can trigger disseminated intravascular coagulation, DIC, leading to what we talked about previously, fragmentation, mechanical fragmentation. Okay. Then extravascular destruction of parasitized red cells in malaria. Yes, because look at the directed destruction. In malaria, the parasite replicates inside, and when it is replicating inside, that eventually or ultimately lyses what? The red blood cells. So I'm saying that 22 answer is all of the above. Okay. 23. Black water fever is caused by A, falciparum malaria, B, acute intravascular hemolysis, C, or acute renal failure, and D, all of the above. So black water fever is caused by what? All right. So black water fever, of course, remember, is a severe complication of Plasmodium falciparum malaria, right? This is very simple and straightforward, and we know that in the same black water fever, there is a characteristic of intravascular hemolysis. This is what causes dark urine and hence black water. Okay, black water, because of the dark urine, leading to hemoglobinuria and often resulting in acute renal failure. So what are we saying? What we are saying is all of the above is the correct answer. Acute renal failure, acute intravascular hemolysis, and falciparum malaria, all these are causes of black water fever. Okay. 24. Haynes bodies are formed in A, oxidative intravascular hemolysis, B, Wilson's disease, C, chemical poisoning, and then D, all of the above. Okay, so Haynes bodies, these are denatured precipitate hemoglobin within RBCs, right? So you see those dots, those dark dots. I can even picture the RBCs right now. So that is precipitated that is precipitated hemoglobin. This is the right term to use in hematology. Precipitated hemoglobin, which are denatured. So they are actually a hallmark. These Haynes bodies are a hallmark of oxidative damage, which can be caused by drugs. Okay, not only drugs but also chemicals, not only chemicals, but also in enzyme deficiency such as what? G6PD deficiency. Now, Wilson's disease is copper toxicity, isn't it? Copper toxicity, when you talk about Wilson's disease, can also cause oxidative hemolysis, and it's actually the primary and most direct association in this case is actually with the oxidative stress. So not choosing all of the above this time around. I'm saying that oxidative intravascular hemolysis, oxidative intravascular hemolysis are the ones that are, that's where Haynes bodies are formed. Okay, 25. The most common hereditary hemolytic anemia in Northern Europeans is what? Hereditary spherocytosis, hereditary hepatocytosis, hereditary stomatocytosis, pyropoikilocytosis. Which one is the correct answer? So the most common hereditary hemolytic anemia in Northern Europeans is what? So when you look at question number 5, this is direct, isn't it? And the question is being asked direct. The answer is hereditary spherocytosis. Okay, this is straightforward. There's no mechanism. There is hereditary spherocytosis. This is the prevalence. The hereditary spherocytosis is the most prevalent inherited red cell membrane disorder. Yes, in people that stay here, or that live here, or that are Northern Europeans in nature. Okay. or the people of Northern European descent. That is a bit specific. Okay. Okay. So from your notes, you are able to review that there is an incidence of about what? 1 in 2,000. So there is an incidence of 1 in 2,000 people of Northern European descent. So A is the correct answer. All right. The basic defect in hereditary spherocytosis is what? A. Spectrin deficiency, B. Ankyrin deficiency, C. Band 3 deficiency, and D. All of the above. What is the basic defect in hereditary spherocytosis? So hereditary spherocytosis, just to explain, is caused by mutations in genes encoding the proteins involved in the vertical linkage of between that membrane of the red blood cell skeleton and also the lipid bilayer. Remember the components or what constitutes the cell membrane, right? So the cell membrane of the RBCs, so its skeleton and also the lipid bilayer, you find out that this is where these proteins are. And then deficiencies in spectrin, ankyrin, and band 3 or protein 4.2. Remember in your notes, can all lead to the hereditary spherocytosis phenotype. With B here, the ankyrin deficiency being the most common. But in this case, we are saying that according to question number 26, the best defect in hereditary spherocytosis is what? We'll say all of the above. Okay. If the question can be phrased in otherwise, we can understand, but we are not saying which one is the most common basic defect in hereditary spherocytosis by saying the basic defect. All these are basic defects. Okay, so this question was supposed to be phrased. In this case, you need to just understand the English that is here. So number 26, that's the answer. Number 27, the loss of membrane in hereditary spherocytosis is caused by what? So the loss of membrane in hereditary spherocytosis, A, release of parts of the lipid bilayer not supported by the skeleton, B, proportional loss of cell volume, C, both A and B, and D, neither A nor B. Which one do you take? The loss of membrane in hereditary spherocytosis is caused by A is the correct answer. Release of parts of the lipid bilayer not supported by the skeleton. Yeah, I'm just from saying something here. So we need to take note that hereditary spherocytosis, what happens is there's the uncoupling of what? The lipid bilayer from the underlying cytoskeleton. That's the skeleton that we are referring to, by the way, here. It's the cytoskeleton, the skeleton of the cell. So what does this lead to? There is then, after that uncoupling, there is the formation of what? The creation of the unstable blebs of unsupported lipid bilayer. And these are actually lost and vesiculated as the cell travels through the circulation. So they are lost and also they are vesiculated when the cell is going through the circulation. What do you think this can result from? This results in a loss of what? A surface area. Without, now look at this, there is loss of surface area without the loss of what? The cell volume. What will that lead to? The cell now will be forced to assume the smallest possible shape for its volume, which is a sphere, spherocytosis. I've just discussed the mechanism. They're all mechanism from this question. So the answer that we pick is what? A, 27A. All right. 28. Southeast Asian ovalocytosis is caused by A, deletion in band 3 protein, then apart from band 3 protein, Southeast Asian ovalocytosis, deletion in band 3 protein, resistance to malaria parasite invasion, autosomal dominant inheritance, and all of the above. What do you think is the correct answer here? So look at this. I'm trying to there are two answers that are correct. There are three answers that are correct here. Look at this. So Southeast Asian ovalocytosis, it is caused by the 9 amino acid deletion in the band 3 protein, right? So A is correct in this case, and it is inherited in an autosomal dominant pattern. So isosome, yes, I see autosomal dominant. And then resistance to malaria parasite, this is also correct because it confers resistance to malaria by making the RBC's membrane rigid, and also resistance to invasion by Plasmodium species. So this is also correct. So I'm saying that all of the above is the correct answer in this case. All right. Okay, so question number 30. G6PD deficiency is inherited in A autosomal dominant manner, B autosomal recessive manner, C sex-linked manner, and D mitochondrial manner. Okay, so what are we saying about this? The G6PD deficiency. For G6PD deficiency, we know that the gene for the G6PD enzyme is located on the what? On the X chromosome, that we must know. I think we discussed this last time. And we know that since it's on the X chromosome where it is located, therefore it is inherited in an what? X-linked recessive pattern, right? So which one do you think is the answer here? So this means that when we say X-linked recessive pattern, like we did last time, we said this means that males are predominantly affected and females are what? Are usually the carriers. So in this case, we are saying that the correct answer is the sex-linked manner. Okay, sex-linked manner. Then we go to question number 31. The most common clinical syndrome in G6PD deficiency is what? This is number 31, acute hemolytic anemia in response to oxidant stress. Before you go in further, this is actually correct. Then neonatal jaundice, congenital non-spherotic hemolytic anemia, and all of the above, these are not really the correct answers. Why are we saying acute hemolytic anemia in response to oxidant stress is correct? Because, of course, all these can occur, right? All these can occur. But the classic and the most common presentation of G6PD deficiency is what? An acute hemolytic episode, okay, which is triggered by the oxidative stressor, such as, what are those? Antimalarials, remember. So drugs, antimalarials, and also apart from antimalarials, sulfur drugs also can trigger this oxidative stress. And also fever beans, most common fever beans or infections. I think we had a series of questions that discussed this even last time. Okay. Hence, bodies in G6PD deficiency are seen in peripheral blood smear, reticulocyte preparation, both A and B, neither A nor B. So, hence bodies are not really visible. Okay, they are not really visible on the standard read GIMSA stained blood smear. So they require they require the supravital staining, like methyl violet and all that, isn't it? So they are actually best demonstrated in a reticulocyte preparation, because which uses such a stain, reticulocyte with supravital staining, and the spleen actually removes efficiently these hence bodies, so they often absent, isn't it, in chronic phases. So this is just to remind you that they're actually absent in chronic phases. We're just not. So hence bodies in this case, reticulocyte preparation is the best. Best seen in reticulocyte preparation. 32 is the correct answer. Pyruvate kinase deficiency is most commonly inherited in an A autosomal dominant manner, autosomal recessive manner, okay, X-linked manner, or mitochondrial manner. The correct answer actually is autosomal recessive manner. Autosomal recessive manner. So autosomal recessive manner, why? Because we know that PK, which is the pyruvate kinase, is the most common enzyme defect of the pathway, this common pathway. Which one is it? The glycolytic pathway. And it is actually inherited in an autosomal recessive pattern. So 33B is the correct answer. Then 34, methemoglobin is the derivative of hemoglobin in which the ion of the heme group is in the what? A, ferrous state, B, ferric state, C, both A and B, D, neither A nor B. Which one? Which answer do you pick from here? So methemoglobin is the derivative of hemoglobin in which the ion of the heme group is in the what? Okay, so we know in normal hemoglobin, normal hemoglobin, the ion is in the ferrous state, isn't it? Which can bind oxygen, we know that. And then when we talk of the methemoglobin, the ion is oxidized to the what? The ferric state, which cannot really bind oxygen, leading to what? The functional anemia and cyanosis. So we are saying that ferric state is the correct answer. All right, 35. The most common cause of congenital methemoglobinemia is due to deficiency of the what? A G6PD enzyme, pyruvate, pyruvate kinase enzyme, cytochrome B5 reductase enzyme, and spectrin. The correct answer here is the most common cause of congenital methemoglobinemia is due to deficiency of the cytochrome B5 reductase enzyme. The body has a system, right, that reduces the methemoglobin back to hemoglobin. And the most important enzyme in that system is the cytochrome B5 reductase. Okay, so a deficiency of the cytochrome B5 reductase enzyme leads to this condition here, congenital methemoglobinemia, just to be specific, right? 36. Methemoglobinemia results from decreased methemoglobin reductase, enhanced methemoglobin production, both A and B, C, D, neither A nor B. So the best answer here is both A and B. We know that from what we've discussed previously. So both A and B are actually things that leads to methemoglobinemia, because we know that this methemoglobinemia can occur due to the imbalance between the oxidation, if you can see these statements, oxidation and what? Reduction. And when there is exposure to oxidizing agents such as drugs or chemicals, that will lead to what? Increased production, right? And when there is a deficiency in that enzyme, the cytochrome B5 reductase enzyme, that will lead to what? Decreased methemoglobin. So yeah, straightforward, right? 37. Which of the following is a feature of intravesicular hemolysis? Which of the following is a feature of intravesicular hemolysis? Hemoglobinemia, hemoglobinuria, hemosidenuria, and all of the above. I think this is a repetition, right? We said that all of the above are the correct answers. So this question just reinforces the key lab findings of intravesicular hemolysis, which are the hemoglobinemia, hemoglobinuria, and also hemosidenuria. So do not really worry much about, no, there is the kind of repetition. This is now trying to make sure that we embed the information that we've learned in this lecture into our heads. Then which of the following is a feature of extravesicular hemolysis? We also discussed this, and under 38 we said that a feature of extravesicular hemolysis is all these things that we are seeing here. Spherocytosis, apart from spherocytosis, so we are saying all of the above. Let me just say this, all of the above. Increased reticulocytes, increased bilirubin, and all these are the features of extravesicular hemolysis, where RBCs are destroyed in the spleen or liver. Yeah, that's what we discussed. Which of the following, okay, this is still question number 38. Okay, it's able to move now. So question number 39, which of the following is a characteristic of warm autoimmune hemolytic anemia? A, antibody reacts strongly at 4 degrees Celsius. This is wrong. Antibody is usually IgM. We say it's IgG. Then here it's 7 degrees Celsius for warm. Then spherocytosis is prominent. This is actually correct. Okay, this is the correct answer on number 39. Question number 40. Which of the following is the characteristic of cold immune hemolytic anemia? Antibody is usually IgG. Antibody reacts more strongly at 7 degrees Celsius. Agglutination of red blood cells on the cold. This is actually the correct answer. Okay, not all these that are remaining. We're just more like revising and enhancing knowledge. Which of the following is a mechanism of drug-induced immune hemolytic anemia? We said that all of the above. Okay, all of the above. Autoimmune hemolytic anemia and all those. These are just repetitions. Then, which of the following is a feature of hereditary spherocytosis? Splenomegaly, pigment gallstones, aplastic crises, and 42, we actually say that all these are a feature of hereditary spherocytosis. Splenomegaly, pigment gallstones, and aplastic crises. 43. Which of the following is a feature of hereditary elliptocytosis? Okay, microspherocytes, poikilocytes, splenomegaly, and on number 43, we actually said that poikilocytes here and also splenomegaly are the features of hereditary elliptocytosis. Why? Because elliptocytosis on the blood smear, first of all, we didn't discuss this one. It shows elliptocytes, right? And other misshapen cells such as poikilocytes. So patients can also have splenomegaly. Why? Because there is extravascular hemolysis. And microspherocytes are not really the typical features of hemolytic elliptocytosis, no, but rather hereditary spherocytosis. So we say this D here is the correct answer. 44. Which of the following is characteristic of Southeast Asian ovarocytosis? We said all these are what? Characteristics of Asian. Okay, this is identical to another question that we discussed. Okay, and then question number 45. Which of the following is a clinical feature of G6PD deficiency? We said that all of the above, which is acute hemolytic anemia in response to oxygen stress, neonatal jaundice, congenital non-hemolytic anemia, and yeah, all these, we are saying all these the clinical features of G6PD deficiency. Yep. Number 46. Which of the following is a laboratory finding G6PD deficiency during a crisis? Bite cells and blister cells, we did not discuss this. Hence bodies, features of intravascular hemolysis, and all of the above. So 46, which one is it? When we talk of the bite cells and blister cells, these are RBCs from which hence bodies have been pitted out by the spleen, right? So they are actually there during a hemolytic crisis. Then hence bodies themselves, these are denatured hemoglobin. On special stain, you're able to see this. Intravascular hemolysis, this one, that's where there is hemoglobinemia and hemoglobinuria, which can actually be present. So all of the above are laboratory findings in G6PD deficiency during a crisis. Okay. Then 47. Okay, 47. Pyruvate kinase deficiency is the most common erythrocyte enzyme defect causing acute hemolytic anemia, methemoglobinemia, chronic congenital hemolytic anemia, and polycythemia. Okay, acute hemolytic anemia, methemoglobinemia, chronic congenital hemolytic anemia, and polycythemia. And the correct answer here is chronic congenital what? Hemolytic anemia. Why are we saying this? Because of course, G6PD deficiency is the most common overall, but when we talk of pyruvate kinase deficiency also, we say that it's the most common enzyme defect of the glycolytic pathway, and it leads to the chronic lifelong hemolytic anemia, which is congenital. So G6PD deficiency, when we remember well, we actually find out that it's actually episodic, so it doesn't really fit here. Okay, so question number 48. Congenital methemoglobinemia is most commonly caused deficiency of the what? All these we said, I think, not I think, but we're just from discussing this. Cytochrome B5 reductase enzyme. Okay, 49. Which of the following is the mechanism of intravascular hemolysis? We said that I think we did discuss this. Which of the following is the mechanism? We didn't, no. But we actually tackled questions related to this. So intravascular hemolysis, you need to know that intravascular hemolysis, its mechanism includes, of course, there is mechanical damage. Okay, mechanical damage like fibrin strands in disseminated intravascular coagulation, and also thrombotic thrombocytopenic purpura. Okay, and then all this leads to the release of the free hemoglobin, which is actually option C here. Yeah, leads to free hemoglobin. So when you look at option A, describes matched hemoglobinuria, right? Matched hemoglobinuria, which is a specific benign form of intravascular hemolysis. But options B and C, when you look at options B here, let me use this one. When you look at option number B and also option number C here, this is broad. These are broader and fundamental mechanisms. So we choose D to be the correct answer. Why? Because of course, in intravascular hemolysis, there is deposition of fibrin strands. An example is DIC and TTP, and then the release of free hemoglobin. That is because of the same mechanical damage. Right. Last question, which is question number 50. Which of the following is a characteristic of matched hemoglobinuria? We actually said this. We said damaged red cell between small bones of the feet, prolonged matching or running, absence of red cell fragments. All of the above actually characteristics of matched hemoglobinuria. Okay, and therefore this is the end of our first tutorial on hemolytic anemia, taking an hour to actually revise. Thank you for your time. Thank you for listening. Please subscribe, like, and comment. These three is what I want you to do, right? It's what I want you to do. So thank you for listening. Until next time, when we now look at the clinical scenario questions. Yes, clinical scenario questions, which we'll be able to discuss. Thank you so much for listening, and have a great night or have a great evening anytime you listen to this. Have a great day though. Yeah.